Good afternoon. We are so excited to be here and to share from what we know and learn from you as well. I mean, earlier we'll be having like a lot of good discussion, and I'm hearing a lot of good questions and a lot of experts in this room. So I hope by the end of this session, we can collect some good thoughts and keep this energy going. My name is Mohammad Alhabbal, Medical Director of AdCare Hospital in Worcester, Massachusetts. Family medicine board certified hospitalist. And then I shifted down from the hospital-oriented regular hospital to more hospitalist directed into the addiction. And this is where my main role at AdCare Hospital. We can expand more as we know, as well as I run a primary care setting, more focused on addiction medicine. So your patients who have substance use disorder, I'm happy to be their primary care and carry along with their closer. Yes, closer. I'm sorry. So your oops. I'm sorry, a little bit excited. Yes. So your patient who has substance use disorder, I will be their primary care. And I started this module several years back, and we are growing on it as well. Having said that, I will have my colleague introduce themselves as well, and then we can carry on with your questions, and we can answer it to the best we can.
Hey, once again, I'm Shorta Yuasa. I'm the medical director at Boston CTC. One thing, I do not consider myself an expert, full disclosure. So I hope to be learning right up until the day, my last day. So anyway, I'll do my very best. Thank you.
Hi, and I'm Laura Kehoe. I'm also not an expert in the sense that I think everybody in this room is an expert, so we're going to work through some stuff together. I am one of those primary care doctors who was Dr. Gudis's, I guess, attending 22 years ago when I first started treating people with buprenorphine in primary care. And fast forward now, have had the great luxury of being the medical director of the MGH Bridge Clinic, and under Dr. Ginter's leadership at Brightview. She's our state medical director. I'm the medical director of 3 OTPs where we're really trying to lower barriers to care and do some innovative work to make it more patient-centered. So I'm here to share that experience and also learn from my colleagues and from all of you. I do inpatient work as well in a very small role, but largely outpatient.
Thank you. I would like to talk a little bit, but at the same time, I would like to energize the audience and for questions. So feel free, if you would have a questions, either come down or raise your hand, come down, etc. So we can communicate and make this 45 minutes as fruitful as possible. A little bit of background about AdCare Hospital. Some of you may know it, some of you do not. It is located in Worcester. It is established over 40 years ago as a doctor's hospital. And then a new leadership came in and changed to AdCare Hospital. The main reason for establishing this hospital is to care for patients with substance use disorders. Back in the days, I was talking about like 40 years ago, mainly, and still is somewhat, alcohol use disorder was mainly spread. So it was mainly for alcohol use disorders. So as things evolved, and as the opioid use disorder evolved as well, that expanded to cover opiate use disorder. Roughly speaking, it is 114 beds. It is level 4 hospital. I think it is the only hospital in the state of Massachusetts that's level 4 hospital. There is one related to, I believe, it's Stewart Healthcare, which is probably around like 20 beds. Uh, so we admit patients as if they are regularly coming to the hospital, and they need to have substance use disorder as the main reason for their admission. Of course, we take care of them through like detox protocol and so forth, and we care for their medical problems. We do our best to transfer their care from the hospital to their primary care or to the MAT on the outside. So as you can tell, a lot of resources to treat as well as to educate. So we open it up for residents to do their rotation. I mean, they come from UMass Chan Medical School, as well as mid-levels. And I would invite any of you know students to reach out to Adker Hospital so we can facilitate their rotation. So they can earn their clinical hours. As we speak now, we have an agreement with Westfield Physician Assistant School, and they come rotate with us. We have a fellow from the psychiatric department who is a psychiatrist and doing fellowship in addiction medicine. We have nursing students as well come and rotate with us from nearby colleges. So we are trying to spread the message educationally, and they can see what we do in a way that can carry on for the rest of their career.
I think we have one question that came through. Do you have it on your phone? Maybe we can read it and we can all dive into that. That might be, because it kind of exemplifies, I think, a bunch of questions that come out, especially reflecting a lot of the changes. Let's see. This came from the audience. I can pull it up. I can read it. I would like to ask the panel their opinion and recommendations regarding split dosing. I think it's a great option for many patients. My concern is when a patient is on split dose and continues to use illicit opioids. I consider the diversion risk to be too high and to continue split dosing in this scenario. I consider split dosing to be a privilege, like unsupervised dosing. So, Mohammad, did you want to start? How would you address split dosing and this person's concern about diversion and it being a privilege?
Thank you. So I would say focus more on the inpatient side, and then myself or my colleague can expand on the outpatient sides. Split dosing is there, it is available, it is reliable. However, is it for every patient? Probably not. Who are the good candidate for those patients? As we probably most of the audience are rapid metabolizer of the substrate of the P450, A3A4, and the 2D6 substrate. These are very good candidate for that. How you will find that? Basically, on their clinical manifestation, if they are showing a craving, as well as if they are using on their current dose. And the question is, can you split the dose? Yes, you can. And we see, let me answer this question more focused on the inpatients. When I have a patient coming to my hospital and on a high dose of methadone, let's say, for example, 150 or 200 milligrams. And the reason for him coming, not only if he's using opiates, he's using alcohol use disorder, I would not be surprised that he's showing withdrawal symptoms. because of the concomitant use of alcohol in addition to the opiate. So for this patient, I would prefer to split their dose while they are on the or while they are on the inpatient, and we'll see how they do. Of course, you can measure it with their clinical presentation. If they are less sedated, more active, more participating in the program, that you will give them the second dose. If they are less than that, you can defer the second dose and you can change it accordingly. I would defer to the outpatient guys.
Okay.
I think, no, go ahead, Shorta.
So how I would approach this at our clinic is, first of all, I gauge. So what we talked about earlier, this is it active use or is this like a recent lapse? What kind of effort has this person made towards recovery? Is this client otherwise engaged in their treatment? So I would definitely individualize this. I would go case by case on this. But the other thing that would sway me towards in favor of split dosing is if this patient has chronic pain. And what I'm hearing is that, over the last 3 months, there's been this escalation in dose, but it's the same thing. Towards the end of the evening with this QIM dosing, the analgesic effect runs out and they are riddled with pain. And it's and this chronic pain that's documented and we've dealt with before. In that kind of case, I would weigh the risks and benefits, and I would probably wait, and as long as there's no behavioral issues and that the illicit fentanyl use is something that was sort of more of a lapse and that has been otherwise stable and otherwise engaged in treatment, I would consider split dosing to assess the chronic pain. The rapid metabolism is another. Rapid metabolism is another issue that I would like to address. So by getting peak and trough, possibly, and if not, if the story, as you said, if the scenario fits, despite the escalation in dose, there's withdrawal symptoms that later in the afternoon through the night, and they're just just really sick by the time they're dosing the next morning, I would consider split dosing.
Yeah, so I agree. And I think that we have so much that we've learned. I think the split dosing, just taking a step back, is what are the patient's goals? I think we've heard the name of the game with this, as it is looking through the lens of every other chronic illness we treat, is what are the patient's goals? What's the evidence and what can we do to individualize it? And I think historically, and this question really highlights beautifully, some of the important things that we can do, and also some of the things that we really need to dismantle and not do anymore, which is, we hear over and over again, and we know the data, this is a life-sustaining and life-saving medication. We need to liberate it as best we can. And so I think looking at medication as a privilege, a life-saving medication like this is a privilege, if we can reframe that thought, that this is something that the patient really, really needs, and we need to figure out what's the best and safest way to get it to the patient. And whenever I'm thinking about split dosing, I totally agree. I think about pain. I think about rapid metabolism. I can't remember the last time I checked a peak and trough.
I know.
Been years. It's based on clinical manifestation. If somebody says at my peak, 2 to 5 or 3 to 4 hours after I dose, I'm really sleepy and then it wears off. To me, that's somebody who we need to make a change, and splitting that dose is definitely something that's on my my plan with the patient, if that works for them. But there are also people, they don't have to necessarily have a reason. We learned this with buprenorphine. We were told this is a really long acting medication, but there's certainly a peak. There's certainly a wear off after a few hours. Many people, once a day isn't the right dosing regimen for them. And it may be they're, all day working and they need something at the end of the day. So splitting their dose may be actually a much more therapeutic and beneficial intervention than just jacking up the dose or saying, try harder. And it's a privilege when you get a negative toxicology for us. So I think really reframing that, individualizing it, talking to the patient, finding out what their symptoms are, what works for them. If taking it twice a day is going to make it more helpful. I'm actually more concerned when I'm splitting someone's dose and they're not at their goal, if their goal is abstinence, that if I'm going to actually give them more take homes and then they're at a subtherapeutic dose and then they're continuing to struggle and I don't get to see them back, to actually advance their dose more quickly. I'm actually more concerned about that than diversion. And I'm not saying I don't, I'm not concerned about diversion, but as we know, the diversion literature tells us that most people who are diverting methadone are doing it to help people who have opioid use disorder and can't access this care. So the answer to decrease diversion is to increase access, but that's another issue. So my approach is that, and I don't make people have to prove that, and we can follow people very closely, even if they are getting that split dose. You think about it, you split it, it's say a BID dose, giving somebody a portion of a daily dose and then seeing them back in a week. Or, if you do what's called a 2-3 split, they get a couple of doses, they come in to tell you how they're doing, get another dose, and then 3 more doses. That is extremely high touch for a life-saving medication. So I think just reframing how we're thinking about the daily dosing and split dosing is in all of our best interests, and never worrying alone. And
That's actually, Laurie, that's pretty funny that you mentioned that. I'm just looking back. I can't remember the last time I took risk of diversion into my calculus for split dosing. I can't remember the last time. Maybe longer than the last time I ordered a peak and trough. So
yeah.
So
maybe I should be.
Yeah, a little bit expansion on this subject. We need to remember always our pregnant patients as well. They are towards the 3rd trimester. The expectation that the methadone dose will be the same, probably not, right? So keep that in your mind when you have a pregnant woman as she is moving along with her pregnancy. Another highlight as well, the medication tolerance, meaning if they are having any side effects such as nausea, right, with higher doses. So keep that in your mind. If you split the dose, if that can be helpful in having them maintain compliance with the program, right? The downfalls is we attach and we look at the big picture, the cost, right? Is the patient able to, if his healthcare carrier can cover the split dose, is he able to do that, right? So this is something you need to take into consideration. And like the if that is not possible, right, increasing the dose probably is the way to go, and monitoring him, right? So along those lines.
Yeah.
So with pregnant clients, that's a totally different category. They're given split dose just because they want it. So it's not even part of this discussion. Yeah, it wouldn't be whether, she's using or not. That's,
Yeah, standard of care.
Yeah.
Yeah, it's interesting. I had a patient in her first trimester who immediately said, "Oh, we'll split your dose and let's go ahead and do that." And she came back after a week and she said, "Please put me back on once a day because I keep forgetting. I'm working, I'm chasing my 4-year-old. I have too much. I'm forgetting the dose, and then it's late and I'm too tired to get up and get it." So again, we know that by definition, pregnant women become rapid metabolizers, and the best practice and standard of care is to split their dose. But we have to go back to what the patient wants and can do. And so I totally agree. She's now back on her split dose, and Dr. Gray is co-managing her at Hope Clinic with us. So
we are absolutely available for questions. And so I'm very excited about this panel because these are people I very respect and very much want to have you guys learn from them. And so if there are burning questions that you have, come on up and just, we can sort of take them here, or you can call them out and then they can repeat the question if that's more comfortable. I think one of the things that certainly has come up a lot is, and we haven't talked about it all today, is the QT piece as well. And if somebody has cardiac related issues that have to do with their dose, I think sometimes I've seen people split their dose as well to reduce that peak that may be leading to some abnormalities, that you can sort of keep them on methadone without having to eliminate one of 3 medicines to treat them. So do you mind saying something about that from a cardiac perspective, if you've negotiated that piece with cardiologists?
yes, you want to start?
Sure. So I just in the hallways just talked about this one particular case. The gentleman that I met this week is a 55-year-old gentleman whose current methadone dose is 50 milligrams. It's only 50 milligrams. He does use both fentanyl and cocaine, and that the cocaine part becomes important. And so it was his annual physical. So, as I do with every patient, I'm doing some prep work and I'm going through, and, I just came back to Boston CTC in February. So I didn't know that he was admitted at BMC back in July of 2023. And he was there for abdominal pain. And while there, he had non-sustained PVCs. And so he was on methadone then. And they got an EKG, which showed a QTC of 550 something. It was 552 or something. So it's all very elegant, very BMC. So what they did was, check this out. They took him off of methadone and treated him with Dilaudid, and I forgot the other medication. I think it was morphine. So they treated his opioid withdrawal, and they actually faxed over discharge along with a discharge summary, series of EKG that showed that when they took him off of methadone, and put him on, and he was just being treated for opioid withdrawal with morphine and Dilaudid, his QTC went down to 430 something. That's completely normal. But this is the kicker. And on the consult note, they had a lengthy discussion with the gentleman, asked him if he wanted to be switched over to buprenorphine. And he said, no, I use fentanyl. I use the stuff on the street. I just never felt right with buprenorphine. Please put me back on methadone. So he got put back on, he got discharged back to us on methadone. And, and I'm seeing him like, a year later, like, have you had any fainting spells? Yeah, he hasn't, he's been doing well. And we talked about cocaine and arrhythmia with cocaine, and he wanted to go up on his dose. I am going to ask him to get another EKG. I did raise his dose. And we are going to, and we have to have this, and I documented clearly that he still wants to be on methadone. So, I am not ready to say, I want to do away with getting EKGs, because that's not true. 2 of my methadone patients in my 12 years of doing this, and then 1 patient when I was an ER doc. So 3 patients, methadone patients in all, had Torsade. So it's not nothing. I think the incidence is, the Swedish study had 42 per 100,000 PVC of Torsade on methadone. So it's not nothing. So I'm not prepared to say, let's get rid of the EKGs. I don't want to do that. I'm also concerned about clients getting medications like Seroquel that increases QTC. So I'm actually more concerned about that, and also stimulant use, especially cocaine, for arrhythmogenesis. So yeah, so I'm like in the gray as usual, and when it comes to anything in addiction medicine.
Yeah, and not surprisingly, I agree. And I think that this is a risk benefit we're fighting with
Right,
fentanyl.
right.
You have a patient who's telling you, this is what I'll take and this is what's helping me. And even with the PVCs and the prolonged QTC, it depends which cardiologist you talk to. This is something, his risk of having Torsade de Pointe and fatal arrhythmia is still much lower than every single day his risk of dying of a fentanyl overdose. So getting him on any kind of MOUD that's going to work, and methadone, and you document the risk benefit, and trying to get him as therapeutic as possible.
Yeah.
Agree. I think the thing that is really hard is that, there's not surprisingly so much heterogeneity about which, the whim of the chief medical officer, medical director, or, whoever is deciding where the cutoff is that a person has to get an EKG. Not all OTPs have EKG machines. Nobody can get primary care anymore. And even if you are, it's another barrier for people to do. And just like any other test that we order in medicine, how is it going to change our decision making? And what is the efficacy and the benefit for predicting? And so I feel very strongly, based on the data that we have, and having consulted with many really smart cardiologists, one of whom actually worked with Dr. Ginter in methadone, that we spend too much time worrying about that and not enough worrying about the real risk of expanding the methadone. So I tend to be somebody who's a little bit less concerned about that, no concern, still screen for symptoms, other medications that could prolong the QTC or put them at risk. But again, going back to that risk benefit.
So, I called the people that make that Cardia, that smartphone app that does the 1 lead and
Yeah.
6 lead. And I want to know, so can you guys read QTCs? Does your product read QTCs? And I was told, no, we don't. They're not FDA approved for reading intervals. So I tried. So we have to get this 12 lead. It's cheap.
This is a question for Dr. Alhabbal. Ari Kriegsman, I work at BHN. One of the things I do is I oversee our Carlson Recovery Center, which is a 3.7 level of care. And one of the difficult positions we're in often is we have a patient in front of us who's come for our care. And in reality, they kind of oversee the level of care that we can offer. Maybe somebody comes in with heart failure or cirrhosis. And we know we're often left with 2 options. One is to say, like, can't take care of you and maybe send them to ER and they're lost to care. Or we keep them, which is what we usually do, because we know they're coming for care, they're at a vulnerable moment, and we want to hold on to them. And so I think I'm asking, as sort of I think the only 4.0 in the state, how we might think about creative ways that other 3.7s like mine, when we're coming across cases that need a higher level of care, how we could expedite referrals to add care, because it feels like we could probably make better use of it for the most complex patients in the state who need that level of care. So I don't know if you have any thoughts about that.
I wish I have this magic tool, but as they say, like if you can bring one fish to the sea back, we can start our process, right? So I think connecting the dot in between your center and the surrounding area on the transitioning of care and what you have and what they can help you with, I think that would be very helpful. We do our best for our patients who do not have access to MAT. We'll try to facilitate that. If they don't have to primary care, we try to facilitate that. If they don't have access to aftercare, we'll try to facilitate that. Again, I mean, with the help of the challenge that is going on, that can be challenging, but at least we can start from somewhere. And as we know, I mean, we know that addiction disease is relapsing. It can be a relapsing process, right? So if you tried and it did not work, you can always give it another try on the second time and so forth and so forth. So along those lines, but as one of like I'm very sure everybody in the room had this experience, like don't give up on the patient and don't have the patient give up on you. Just keep your door open, even like on the inpatient or the outpatient, as much as you can help to connect the dot, I think the way to go.
Yeah, maybe just one quick follow-up comment. We've sort of been proactively actually reaching out to AdCare in this regard. We've had sort of just been in this tough position a lot of times. And I want to say we have had some success in connecting with your organization. Recently had our first 2 patients who actually transferred from our level of care to you. And I just want to say this out loud for the rest of the room. If you happen to work in a 3.7 level of care, I think it's one of these sort of moral hazards we sit with every day. We're like, I don't want to let this person go because I know what happens. Yet also I'm taking on a risk of taking care of them. And so I just want to sort of, I would encourage other folks to reach out to you. I'd love to talk more afterwards, because I think there is something as the 4.0 in the state that I think we should make better use of that level of care. I think it's really special. And I would hope that everyone in the state who wanted and need that access to that level of care could get it sort of seamlessly. And so I just sort of put that as a plug as well.
I couldn't agree with you more. Yes.
Hi, Lynn Keneally, physician assistant, and I kind of want to piggyback on one of the things he's talking about right now, because I work both at AdCare and at a 3.7. And one of the things we run into is realizing at the 3.7, the patient is a little more acute. And everyone comes to me and says, hey, can we transfer them to AdCare? The problem is, if we've already admitted them, because of insurance, we have to send them to the hospital, and hopefully they'll send them to AdCare, because we can't directly then admit to AdCare, which is a real frustration, because it's risking losing that patient rather than getting them to a place that would be appropriate in care for them. So
I would say like the AdCare like model is a role model to follow, and the transitioning from one level to the other can be very challenging, especially if the patient being admitted. My suggestion: do your best what you have, get him the best out of the program that he is in, and try to transfer him or transfer the patient out to the second level of care. right? And even like at AdCare, we don't have all the answers, right? If I have a patient with active chest pain, he's gonna go to a regular hospital. If the patient have respiratory compromise, it's gonna go to a regular hospital. Yes, we have patients who have COVID. We take care of them, but if any respiratory or any hemodynamic instability, they are going to the hospital. So I think we can bridge the gap with that. And once they are stabilized, they are welcome to come back and continue their program and transitioning process.
You would almost think that you could do something like make a short list of the non-acute MI worries and respiratory, but have those levels that are too high for 3.7 and maybe pilot it, that could be a direct admission as a start without having to go to the ED, but that would probably require BSAS and such. Just saying, no pressure, you know.
Well, I can expand more about it. I mean, we have, of course, EKG machine, we can do blood work, and we can do stability, but we don't have telemonitor, right? And oftentimes, just like chest pain, this is red alarm. I don't want to play with it, right? So along those lines, on their presentation, if they complain of chest pain, I will send them to the ED for clearance. They can do a couple of tropes, EKG, tele for like few hours. And if they are clear, they are welcome to come back. So along those lines, so we are collaboratively with the community.
I didn't want to break in. Steve Jones from Western Mass. And I wanted to pose a sort of a clinical question about preference of it in the era of fentanyl between methadone and buprenorphine. And suppose you have a new patient who's been using a lot of fentanyl, maybe had recovered from an overdose. What would your thinking be about which of the two medications you would start with?
I can start. Thank you, Steve. So I face that question every day, and I talk to the patients about their options, about what agonists that those would be. I would talk about both options. But I strongly recommend somebody like that methadone, because I have the luxury of being able to offer both of them, and we can do it in a really patient-centered way very quickly. That said, I have some patients, and it's largely, again, because of the structural harm that we've put on people and vilified this incredible medication, that people don't want to do methadone. And so we work to get them on to buprenorphine, and we have many options of doing, we do a lot of low dose buprenorphine, opioid continuation crossovers these days. We haven't had as much success with macro dosing, but the micro dosing is really kind of what we do as our way to get people on it, someone like that with a very high tolerance these days. But I'm always thrilled to be able to, either in the Bridge Clinic or at Brightview, to be able to just get people on methadone and to get them up on their dose really quickly. And to expand take homes, because I have this amazing boss that has really, really put on the map a way to get, look, why aren't our patients getting take homes, and really address it very quickly. So I feel like my tendency now is to really make sure they know their options and not push it, but to really expand when people decline methadone, to really drill down on why they are, and to see if we can kind of dispel and reassure them that it will be a different experience this time. And a lot of times people will choose that if they feel that it's going to be that answer.
So for me, as Laura said, autonomy, autonomy, autonomy. So their preference is number one. But then if they're asking me, which one would I choose? So I get asked this from time to time when I'm handing out Narcan in Mass and Cast. Doc, what do you think? And I have to kind of align with Laura here for heavy, highly highly potent synthetic opioids. I mean, wait until nitazene gets its hold in this region. I think the full agonism of methadone is a lot safer. Also from the standpoint of precipitated withdrawal, pretty much everyone that I talk to in our neighborhood have experienced precipitated withdrawal trying to, and they all know about microdosing too. I've actually learned quite a bit from them. Like, how do you guys do this? So And then the thing, it's like the QTC guy. They just don't feel, even when they're up to 4 films at 32 milligrams a day, they just don't feel great. So, you know, I haven't been recommending 40 milligrams yet, but for people in early recovery and active heavy use of highly potent synthetic opioids, I would go with methadone.
One thing, like the patient will not leave the office without appropriate education, information, as well as solid follow-up appointment. I need to let me know what you learned from this. And not only that, I push it a little bit further by engaging the collateral, the family, the friends. I mean, for the patient to come to me and ask, this is huge, right? Such as to get them engaged and to have regular schedule, like same patient, I mean, I'm not teaching you, but like same thing with hypertension and diabetes. This is the chronic module of disease. Just like, come, let's talk about it. Let's see what's option out there along those lines.
Great, Dr. Stahl.
I'm not addiction medicine. I'm mostly consult service. So when we have patients, I've had a few patients on methadone who don't have stable substance use disorder, who have very painful things that are not going to get better, especially infected prosthetic joints that they cannot get replaced until they have a prolonged period of stability. It's sometimes split dosing of methadone is not enough, but it's really a challenge to make a plan for them, especially from our side, of something that might be amenable to an OTP and also an outside prescriber. What, if any, models have you seen that work, or what do you think we need to do collectively to provide some kind of pathway for those patients?
Can I take this one?
Yeah.
Oh, okay, great. So I recently had an experience with this. So I got a call from a palliative care specialist at MGH, and a nurse practitioner about one particular gentleman who had a laryngeal CA and has a stoma, and he was only getting Q-day dosing. And when he was hospitalized for the procedure, while at MGH, the wonderful folks at MGH put him on a split dose. And then they were also treating him with, short acting like Dilaudid while hospitalized. So when he was discharged, they were kind enough, Dr. Petrullo reached out to me. Oh, I'm sorry. Oh, I'm sorry. So Dr. Petrillo reached out to me, and we worked out a plan where we did not only split dose, but we had the palliative care nurse practitioner also prescribe immediate release oxycodone for night for breakthrough pains. It's kind of a long-ish story, but it did actually make sense. He definitely wanted a daytime analgesia with the split dose, but at night he gets the radiation post-radiation pain around the stomach. It's really angry looking. The last time I saw him a couple of weeks ago. And so I am all for it. I think the most important thing was the close communication I have with the prescribers to make sure, because she definitely wanted to limit the oxycodone tablets. And then I started going up on the split dose so that he's covered, he's more comfortable during the day. So I don't know if that helped, but yeah, so it's possible.
I will expand a little bit on it as well. Clearly, those more like complicated cases, right? And most of our patients are complicated. So do not be alone with this journey. Don't be the only champion in taking care of this patient. Get more people engaged, your social worker, your case manager, consult palliative care, consult chronic pain clinic, right? And all of that documented, just like to make sure that you are doing the right thing. Don't have a low threshold for prescribing the medication, but have low threshold for engaging more people and learn from it and move along with the treatment plan. So multidisciplinary treatment plan that can be very helpful in those situations.
Yeah, I couldn't agree more. And I know, Natalie, this comes up a lot. I think that I would immediately do the same thing. That's somebody who needs to be split. And I think there's still this disconnect in a lot of OTPs that we only can treat by law opioid use disorder and you can't treat pain. Yes, we couldn't take over the prescribing of the short-acting opioids, but we can certainly advance, if this was somebody who is endorsing cravings or use, that's because of the pain, that's still opioid use disorder and they have pain, they're on, it's very gray. So that would be somebody we're optimizing, making sure, and allowing and welcoming the short-acting pain medications. I think that this is something that's very low-hanging fruit. And I think that we can't pretend that we're pain specialists. There are some really nuanced pain management that, even though our pain colleagues may not want to prescribe the medication, can be very helpful in guiding dosing, especially given the high tolerance. So, but this comes up a lot. Yeah.
So along those lines, so we are actually at Dana-Farber doing that a lot. Oh, sorry, I'm Charmaine. I'm Charmaine Lastimosa. I'm on the palliative care team at Dana-Farber. And after my fellowship, I was very much the addiction person on just kind of doing some education and having these conversations. And I think our group has been very open to splitting doses in the hospital, figuring out, and I think alongside that, we have really pushed to discuss, or to facilitate collaboration, because I think in the past, possibly patients would be taken over by palliative care, and it may not be the most appropriate thing, because if someone does relapse or recur, they don't know exactly what to do and don't have the exact structures to support those patients. And we really kind of dysregulate a patient who has established relationships with OTPs and with counselors and other community providers. So we didn't feel that that was the most supportive way of going about it. So we've really moved to this collaborative kind of model. And I have to share about a patient that I took care of from Connecticut. And, was really challenged, came in with a head and neck cancer. I think the challenge with head and neck is that it's really debilitating, it's disfiguring. It really impacts so many different layers of life. And she was on an OTP in Connecticut. I couldn't, even if I took over for a short time, her methadone, we kind of have this policy where we closely monitor because of the limitations of our clinic. So we really need to have those high touch points. And there was no way she was going to be able to drive out from Connecticut to see me as often as I would have preferred. So I called her OTP and got in touch with her provider actually quite quickly, which I think is one of the things that I think we could work on. Because I think time to response and the ability for us to collaborate as quickly as possible is really important for stabilizing patients, especially on really complex cancer treatments and things like that, and who are in pain crises. So I was able to talk to her, and she was a former ICU nurse, so it was very much like I have this palliative care view as well. And so we really kind of gelled, and we really worked to support the patient through the end of life. And she ended up, dying in our hospital on our supportive care unit, or we call it the inpatient palliative care unit, on fairly high doses, really close to kind of palliative sedation because of her ramped up anxiety and all of those kinds of things. But it really, going through that process, I think I pulled in like 15 different providers at every step of the way, you know what I mean? And I think we were all very distressed at different points. The OTP teams were looking to us for support because the cancer was just so disfiguring. And so it was really heavy for everybody to kind of. So I think the more collaboration we can have amongst peers, and the, just kind of working with a patient, she was using all along the way, and we were still very supportive of her. So I think you just kind of have to flow with it and connect. I think that, so things that I think could be a bit better. And I'm curious to see what others think about this. But the lack of time, or sort of the delayed time to response, really is the biggest thing. If we can't get a hold of a medical director or a nurse practitioner who's prescribing to talk about split dosing or anything like that, it really stalls the process for the patients, and they really suffer. So it would be great to kind of brainstorm around that. You know, if there are certain structures where we could talk about, you know, someone else that we could talk to. Is the nursing director going to field these calls as well? How do we get, you know, the messages to the right people in a timely manner? And then the other thoughts that we have are, you know, we've heard from other OTPs that, you know, the waivers are really they're limited for certain medical situations. So pregnancy, fast metabolizers, and then nothing else. And I think we really need to expand our thinking as far as that goes and spread the message that really there are so many other things. And we've talked about them here, that prevent patients from going to the clinics. And then at end of life, how do we best support patients? Who do we pull in? How do we, you know, really collaborate and make sure that they stay connected to the people that they've had all along the way, and preserving those relationships? So
Yeah,
anyway.
thank you so much for that, Charmaine. That was really rich. Just as a reminder, we do not need to file waivers to split doses, so that it's a clinical decision making. Now, that's one of the great things with the new regulation. So so don't worry about that. And I think that the communication piece is key. Dose confirmations, though, is a regulation. There has to be somebody on call 24 hours. So if that's not happening, BSAS, you should let them know to see if there's a problem. Sorry, Mike and Jen. Because and it happened to us too, and it helped us figure out operationally what was going on. Why weren't we getting these calls? And we fixed it, and it's better. So it's not a punitive thing. It's really a helpful thing. So that's one. And then two, I think that maybe individually, if there are problems, and you're not getting a response, you know, really pushing and finding out that every clinic has an operations director, and, you know, not to make it, you know, more problematic, but this is something systems wide, there really should be somebody who's available, and that would be like an emergency situation. Just a shout out for tomorrow, Dr. Jim Baker is giving an amazing talk on pain, and at Mixed-App is our guru for these really complex patients as well. And so that care collaboration, again, just underscoring how important it is to have that expertise, and you too, Charmaine. So thank you. Oh, we have 5 minutes. I wanted to just one more thing you had mentioned, Charmaine, about care coordination, and back to the original question about split dosing. I didn't mention this, but in terms of if you are concerned about a patient not being able to manage their medications, you can do what's called a custodial take home, where if there's somebody who can actually help manage that medication, whether it's VNA or a family member or a friend. We actually had a patient who passed away who had decompensated end-stage liver disease, and was a beautiful case of care coordination of multiple different team members, the Somerville Homeless Coalition, our OTP, the amazing hospitalist team at Cambridge Health Alliance, and actually Somerville Homeless Coalition. One of the outreach workers was this person's healthcare proxy, and she actually was the custodian. So we could actually liberate his medications. We didn't have to come in. So when he was staying, you know, at their spot, he had a week's worth of medication, and then he was admitted to the hospital. And so it works. And this was probably one of the most complex patients, I would say, that we've had, Heidi, wouldn't you say? And as painful as it was for everybody, it was really the operations that we were causing more harm to him, and coming up with this plan for him that worked. And so those custodial take homes, if you're really worried about someone who's encephalopathic or for whatever reason, that's something I think that we don't think about enough. And then you just have to file an exception for that.
Complex, but really rewarding.
And do it right, and don't make errors on it, right, Mike?
I can repeat your question, Phoebe.
Yes. Yep.
Right, and the one really strict rule is my understanding that SAMHSA has about surrogates, which I think is what you mean by custodial, is that they can't be somebody who has an opioid or even a history. And so we run into this, and my understanding is pre-COVID, there were more VNAs. It sounds like Central Mass might have more options, but there are definitely times when we're really stuck, and the absence of having a VNA who will oversee methadone, which I'm sure is fraught and related to staff shortages and this sort of thing. Anyway, it's just more of a comment, but sometimes it's really hard.
So on Topeka Street, we can't find VNA agencies that open. So we're relying on chain of custody, surrogacy quite a bit. Yeah.
Yeah.
Um,
Mhm. The chain of custody and
you have a
custodial.
lot nicer voice than me.
Oh, okay, fine.
Mil-
Just saying that it's really hard to find VNA services. So relying on other forms of people, whether it's a loved one, or in this case, it was Care Dimensions Hospice that actually the hospice nurse came to our clinic, picked up the medication, brought it to the Homeless Coalition. So there are ways to do it. I think, the issue of somebody who has a diagnosis of an opioid use disorder, not being I haven't, and maybe I'm going to
I
get in
haven't come
trouble
across
for
that.
this. Are you treating that person? Like
Yeah.
you have to act, like some of it is the interpretation of these regulations, and there are ways to follow people really closely. I get it. If someone's actively using and unstable, and the worry is then this person won't get the medication or something. But I think there are some things that are not very black and white like that. I don't know. Maybe Jen and Mike, is that
Actually, I
something?
literally just handed
Yeah.
Mike Gurney the microphone
Yeah.
to see if he wouldn't mind
Yeah.
exploring a little bit of this further. And he can have that last word after you guys sort of
Yeah.
do a final.
Not to
So
put you on the
thanks, Mike.
spot, Mike.
Yeah, so I mean, chain of custody is certainly acceptable. I'm not sure like necessarily what the limitation is in terms of I know that SAMHSA has said that yes, the surrogate can have an SUD or have any history of SUD. And our hope is that maybe that'll change, but right now that's a limitation with chain of custody.
Yeah.
It's a good question. So I think it's
Yeah, I know. Exactly. Right.
Yeah.
No, that's
yeah.
tricky.
Yes. Yeah.
So one of the
Yeah.
things that's happening right now is those of you who are going to listen to this on YouTube are going to say, what the heck was going on? Because there was like silence and then laughing. And so what was just happening, and then after I explain this, I'll let you guys close out, is that we were talking about the challenge of custodial take homes when there isn't a custodian who is available and does not have a history of an OUD. So we were just having a little discussion about that. So if you hear that chuckling, that's what it was. Thank you three so much. If you want to just say a couple last minutes, that's great. Otherwise, we move along to the next one. Thank you so much.
Thank you all so much.
Thank you.